very brief intro here. Carrie, good to see you again.
Good to see you too, Brian.
I mentioned, who I was to the folks from MacNeal, and the objectives again: physiology, acclimatization, talk about the high altitude illnesses, some other high altitude or altitude related illnesses, diagnosis and treatment, prophylaxis, and prevention. Okay, there it is. So this is 2007, 13 years ago. And my friend Grizz, who's on the right and I'm on the left there in front of Machu Picchu after a 4-day hike through the mountains. And I highly recommend this trip. It's pretty cool. You see a lot, you're out in the wilderness, but you get well taken care of. They have sort of these guides that you have to go with. It's very, very, very well controlled. Here's what it looks like when you go. These are the different days at the bottom. And if you go to the left, that's where you start. And it's pretty high altitude where you start. So generally people try to acclimatize a day or two before they leave. And you go to a peak of about 14,000, and I'll talk about that a little later. And then you end up descending into Machu Picchu on the far right there, which is 7,500 feet, not that high. So by the time you're there, you're in thick air comparatively. Great trip. Let's see, there we go. So the physiology is as follows. It's fairly straightforward. Rapidly ascending, and I'm going to display here meters and feet, but I'm just probably going to say feet just so we can stay on one unit. And a lot of us still think that way, but anyway, probably most of the world is going to talk in meters, but past about 8,000 feet, leads to a decrease in oxygen concentration, which is your PaO2, and tissue hypoxia. And it's this hypoxic stress that causes increased permeability of the vascular endothelium and extravascular fluid accumulation. So that's the underlying physiology, is hypoxic tissues and leaky vessels. Exercising at altitude worsens the problem physiologically, unfortunately, because a lot of people go on these trips to exercise, whether it's a ski trip or hiking trip. So that's an additional risk. About acclimatization, it's a normal compensatory response to this high altitude stress, but it requires weeks, and people's capacity varies. It seems to be based on your own personal genetics. It's not generally related to fitness. So that's very interesting. By the way, again, the things in yellow, I think, are things that are important takeaways. And it's also not related to age necessarily. A higher VO2 max does not confer lower risk. Okay, so you can be a really fit guy or woman at sea level, and you can have a lot of trouble at 8, 9, 10,000 feet. It also doesn't seem to improve with repeated exposure. So you really can't train for it. You can acclimatize, but you can't train for the acclimatization. The best predictor of how you're going to behave or how a patient is going to deal with altitude is their past experience, okay? And many of you probably have been on ski trips and things. My brother lived in Crested Butte, Colorado, which is around 9,000 feet. Essentially every time I went there, I had a headache and couldn't sleep well the first night. And it took me till about day 3 until I was able to ski, and keep up, because I was just so out of breath and tired. So it's fairly predictable. The high altitude illnesses, HAI, sometimes referred to, is a collective term for these different syndromes. And these are the 3 that I think you should try to remember. AMS, acute mountain sickness, HACE, high altitude cerebral edema, and HAPE, high altitude pulmonary edema. So in this case, going back to our physiology, the hypoxic stress causes extravascular fluid accumulation in the brain, which is responsible for the AMS and HACE, right? Acute mountain sickness and the cerebral edema, and the lungs in the case of high altitude pulmonary edema. So it makes perfect sense. All of these do respond to the same type of therapy, which is essentially descent and oxygen. So let's start with AMS, acute mountain sickness. It's the most common form of high altitude illness, generally occurs above 6,500 feet, okay? Not much higher than Denver, really. High altitude headache is a term used for the headache that may precede AMS. So you could think of HAH, high altitude headache, as distinct from AMS. By the way, can Carrie or Poonam just say something so I make sure I still hear you guys?
Yeah, we're still hearing you just
Good.
fine.
I wanted to make sure I hadn't dropped or anything. So just
we're just all muted so we don't bother you.
Just muted,
beautiful.
So
Just want to check, you know, that I'm not talking to myself. And all right. So here we go. Here's a yellow part. So AMS, acute mountain sickness, is very simply headache plus any of these other symptoms: nausea, vomiting, fatigue, malaise, dizziness, insomnia, as I mentioned, I got, and anorexia. Think about a hangover as being sort of typical for acute mountain sickness. High altitude cerebral edema is a progression in the severity of acute mountain sickness. Okay, so it's CNS symptoms, and it's generally above about 10,000 feet. It's actually the least common form of high altitude illness, but can be rapidly fatal. So when does it switch from AMS to HACE? And that's if you get ataxia, altered mental status, irritability, confusion, stupor, or coma, okay? So it's when your headache and fatigue turns into clumsiness and confusion and, you know, difficulty balancing, things like that. Very critical to know those things. Now, HAPE, high altitude pulmonary edema. It's also relatively uncommon, but it's also life-threatening. It's a non-cardiogenic, not cardiac, pulmonary edema. It usually occurs 2 to 4 days after the rapid ascent, above 8,000 feet. So think about that. I was in Crested Butte, Colorado, which is a pretty common, you know, destination for skiing and mountain biking, and that's at 9,000 feet. And I'd probably go up another 1,000 or 1,500 from there for skiing and for biking and things. So you can get this in places that we or our patients go on vacation. This high altitude pulmonary edema can coexist with AMS and HACE. And basically the symptoms are similar to classic pulmonary edema with cough, dyspnea, orthopnea, and weakness. It's the most common cause of death amongst the high altitude illnesses. And there's a very high risk of recurrence, again, if the same person goes to the same altitude at the same rate, they'd be at risk for the same thing. Very quick story, my aunt and uncle came from New York to Crested Butte, again in Colorado, and my aunt got very sick and she was getting short of breath, and she was generally healthy. They basically had to drive her down to Gunnison, which is maybe 1,000 feet or 1,500 feet lower. It's the town you fly into when you go to Crested Butte. Put her on some oxygen, she's fine, right? At that, so it was just that difference of, you know, 7,500 to 9,000 that made the difference there. Okay, so this is our tent that we shared, my friend and I, and we had a team of several couriers carrying our stuff. You know, we had packs, day packs and stuff, but the tents and the food and all the gear was carried by the team. And this is them. So this is for 2 people. We had this group, and this doesn't even show our guide. We had a guide who was very knowledgeable about the flora and the history of the Inca Trail, and he would walk with us and spoke perfect English. And you can see what they're wearing on their feet. These are little sandals that they all seem to wear, except our cook there, the woman, she's wearing tennis shoes. These things are not attached in the back, and these guys literally run up and down the steps. The Inca Trail is full of steps up and down. So if you're going to train for this, by the way, you live anywhere near a building, just go up and down the stairs. That's the way you train for the Inca Trail. And they do very well with just these little sandals. Okay, so some other altitude-related illnesses. One is called altered breathing, and the other retinal hemorrhage. Just want to mention those. So altered breathing in, again, altitudes that are not that uncommon and very common at higher altitudes. It's periodic breathing of altitude, it's also known as. And it's sort of a Cheyne-Stokes respiration. So it's due to variation in the neural signaling during sleep. So when we get hypoxic, it's a respiratory stimulant. But if we get alkalotic, right, if we blow off CO2 because of the hypoxia, it's a respiratory depressant. So it's sort of playing back and forth, toggling between these two kind of classic stimulant and depressant effects on our breathing, right? Initially, think of hypoxia causing increased respiration, making you blow off more CO2, all right? And so what you see is this kind of respiration, Cheyne-Stokes, which we know from our neurology experience and training. Okay, so this is on retinal hemorrhage. Retinal hemorrhage is a rupture of the retinal arterioles. It occurs much higher altitude, so this would be mountaineers mostly. And this is what you can see on exam. Other illnesses related to altitude. Chronic altitude exposure can cause high altitude pulmonary hypertension, and certain pre-existing conditions are exacerbated by hypoxia. This is obvious, ischemic heart disease. And then there are conditions unrelated to hypoxia in terms of physiology. They may be related to thin air, but not because of the hypoxia physiology. So those include frostbite and photokeratitis. So photokeratitis is an important one and fairly common. These are some examples of how it might look to the eye. And what happens is you have a person who comes back from high altitude trip, maybe even skiing, and they don't have adequate eye protection, and they get acute eye pain for 6 to 12 hours after the UV exposure. The corneal epithelium gets desquamated. Okay, so it's sort of like a corneal abrasion type symptom with almost a foreign body sensation and a lot of pain. There shouldn't be any discharge or evidence of infection, but the treatment still includes antibiotic ointments and analgesics, and the surface regenerates like corneal abrasions without a foreign body. Do not treat with cycloplegics or patching, and basically it's preventable with protective eyewear. And most of the good sunglasses today would have that protection. So let's go to risk factors. Risk factors of high altitude illness. Past history, again, the strongly predictive risk factor. The rate of ascent. Vigorous exertion prior to or during acclimatization, which is an obvious issue because many people, again, go on a ski trip to exercise. And they also go to do what? Go to the hot tub afterwards and drink alcohol. So it's a risk to drink in or around these changes in altitude. And then any comorbidities that interfere with respiration. So recognizing high altitude illness, dyspnea, worse with sleep, gait disturbances. And for example, an abnormal tandem gait test would suggest more severe AMS or HACE. Okay, so that if you were with a group and somebody had a headache and they were tired and feeling poorly, it's sort of the sideline quick test you could do is have them try tandem gait, heel toe, and see how their balance is. And decrease athletic performance in general. If their attitude was changing, if they were having neurologic symptoms, they may not participate in group activities or be difficult to manage, confused. The differential diagnosis would include dehydration, hypothermia, and viral illnesses. Those might mimic. And so those are things to keep in mind when trying to determine what's the cause. Diagnostic testing for those who are treating for high altitude illness can reveal the following. High WBC, there can be an increased opening pressure in the lumbar puncture, hypoxemia, of course, on the pulse ox, pulmonary edema on a chest x-ray, or cerebral edema on the CT scan. Generally, if there's cerebral brain effects, the MRI is more revealing. And I won't go through all the details, but there are specific findings that can be seen, and it can remain abnormal for weeks, even years. There could be hemosiderin deposits years after high altitude cerebral edema. My friend took these next pictures. I did not know that this llama was there. And this is a very, very narrow, you can see it's sort of a narrow, maybe 5 foot wide ledge here. And behind me goes straight up and down. Like if you fell, you probably wouldn't die, but you'd break a few things. And he said, hold that right there, hold still. And he took my picture, and then it's the next picture that he got, which is scary. They're reasonably big animals, but he just trotted by right on the edge, of course, comfortably. And there's the llama going by. Anyway, so let's go to treatment. Again, I alluded to the mainstays of treatment: descent, oxygen, also hydration, medications, and in some cases, a hyperbaric chamber. So the medications for treatment, I'm not talking prophylaxis yet. For treatment, you can use acetazolamide or Diamox, the name brand that it had. It's a carbonic anhydrase inhibitor, okay? And it induces a bicarbonate diuresis, all right? So you diurese, it's a diuretic, bicarb, causing a metabolic acidosis and compensatory, what? Hyperventilation. So you increase the CO2 and you're inducing hyperventilation, blowing off more CO2. So that's how acetazolamide works. The dexamethasone, of course, is decreasing inflammation. And as we know, it can cause hyperglycemia. Nifedipine is sometimes used in the pulmonary edema, and then symptomatic management with things like NSAIDs and antiemetics. And this is an example of a fairly portable hyperbaric chamber. And these would be likely stocked in sites where there were people doing high altitude climbs. They're portable, very lightweight, inflatable. They would simulate a descent of 2,500 meters or more, which is significant. And they would be mostly used in awaiting a real descent. So while waiting for the helicopter, the high altitude pulmonary edema climber would be put in this tent or chamber. Sometimes they add oxygen. And it's generally unnecessary for the treatment of AMS, which is the most common in the hospitals or at lower elevations. Usually they just treat supportively with oxygen and medications. So pharmacologic prophylaxis, this is something you might get asked about. Consider it for patients with a prior history of high altitude illness, or if they're going to have to do a rapid ascent, such as tourism to mountain resorts. The medications include some of the same ones we talked about. So acetazolamide, again, it may improve acclimatization and reduce acute mountain sickness. 125 milligrams BID or 250 BID. Now that's kind of the official amount, but I've prescribed and taken myself 250 BID. I did prior to my trip to the Inca Trail, and I don't know if it helped or not. I haven't been there before, but it's fairly, I would say I wouldn't have a lot of barriers to using acetazolamide if somebody was going back to an altitude that caused them problems before. It is banned by the International Olympic Committee as a diuretic for the two reasons that the diuretics can affect your physiology and improve performance, but they can also be used to reduce detection of banned substances in the urine. And the steroid, same dose, 4 milligrams TID of dexamethasone for 1 to 3 days. And this could be prophylaxis for HAPE taken right before the Ascent. It doesn't necessarily improve acclimatization. So steroids probably wouldn't be something we would be prescribing much. And if somebody had a previous episode of HAPE, the best treatment would be to not go to that altitude, obviously. This is a calcium blocker, nifedipine ER, 30 milligrams BID, and that's both for treatment and prophylaxis of the pulmonary edema, just the pulmonary edema, not the cerebral stuff. And then PDE-5 inhibitors like sildenafil, which we know from other uses. So it, and many of you know this, the original generic sildenafil was for pulmonary hypertension and pulmonary uses before it was for erectile dysfunction. It enhances the effect of nitric oxide and causes vasodilation. and it's prophylaxis for HAPE. So think of it, the PDE-5s as for the pulmonary, not necessarily the CNS. It can actually worsen headache. There are lists of the specifics that you can get, and you could just get this from UpToDate or other sources. So they're pretty available. So there's really not that complicated. There's a smaller group of medications to manage. Okay, so I ran into this German guy, and he said, "Are you chewing Coca?" And I said, "No." And he said, "Oh, you got to chew Coca leaves." And we were about to head up to the highest peak of this trip, which is peaking over a mountain at about 14,000 feet. And now I had had Coca tea every day. The our Peruvian Sherpas gave us tea in the morning, and it was delicious, made of coca leaves. And coca leaves are a source of cocaine, but it doesn't provide that kind of a dose or amount for it to have a cocaine effect per se. It is a stimulant though, and I took probably a third of the big wad that this guy had, and I apologize for this kind of gross picture, but it's one of the few that I took on the trail, and it really worked. I was impressed. I felt like it felt like having, you know, a few cups of coffee, but I was less short of breath, and I was actually able to help another climber who was stopped on the trail, and she had her pack down, and she was just huffing and puffing and couldn't get to the 14,000 feet. I took her pack and mine and walked her up to the top, and I attribute it to this Coca. So if you recall my earlier slide, this is the day 2 Dead Woman's Pass. And that's, you know, I took it just before I got up to there, maybe an hour or so, 2 hours. So there's some research on this. Here's an example. Does chewing coca leaves influence physiology at high altitude? This is from 2010. Because a lot of, I think all of the helpers that we had chewed it. It was just like, it's like the local thing to do. In this study, they took just a small number, but it was 10 healthy males. They were local residents in Peru at 2,700 meters. They chewed 8 grams of coca leaves. And I thought this was a funny part of it, that they had a little bit of lime. So next time I go, I'll have to remember that for the taste. It can be a little dry. They did standardized exercise on a stationary cycle ergometer. And compared with 4 healthy controls, they found no difference in blood pressure, O2 sat, pulse, VO2 max, or ECG. But they did show biochemical differences, including hyperglycemic response, elevated glycerol, lactate, and pyruvate. And the results suggested that the coca leaves blocked the glycolytic pathway of glucose oxidation, and basically enhanced our ability to metabolize energy when taking it. Bottom line was the findings suggested that chewing coca leaves does induce biochemical changes, enhancing physical performance at high altitude. And their study showed that the effects were felt over a sustained period of time over physical activity, not days, but hours. So I found that interesting. And my personal N=1 study agreed with that. So let's just talk about prevention. This is the last bit here.
Nice.
The best prevention is to slow the rate of ascent. So the gradual ascent, if you have the time to do so. And you don't have to remember these numbers, but remember the concepts. So here's an example. AMS occurred in 2/3 of climbers taking 1 to 2 days to reach the peak of Mount Rainier, 4,400 meters, pretty high. But only 1/3 of the climbers, so only 1/3 of the climbers taking a week to reach the summit of Denali, which is way higher. Okay, so if people can go up gradually over days, the more time, the better. And most outdoor outfitter toured guide trips will take this into account. And they'll have programs for people to acclimatize at altitudes, and then they tend to go up slowly. I've had a friend who went to Kilimanjaro. That's what they did there. If living below 1,500 meters or 5,000 feet, which we certainly do here, try to avoid ascent to sleeping altitudes above 9,200 feet. So it means that you would try not to go immediately that high and stay a full day. Consider spending one night at intermediate altitude when traveling to elevations that previously caused symptoms. It's all the same message. Go slow. So here's the mountaineer's adage: climb high, sleep low. And what this means is take day trips to higher elevations and then return to a lower altitude for sleep. So for example, when people go to Pikes Peak, which is very high at Colorado, go up by a train, I think a tram, AMS is uncommon if you go for a couple of hours and come back down. But if people stayed up there, I'm sure the majority of people would get acute mountain sickness because it's such a rapid ascent. And then there's a staged ascent is another idea, which is taking several days at an intermediate altitude before the higher elevation. And probably all of you have read bits about climbing Everest, but you know, the groups that go up Everest have this sort of up-down thing, right? I mean, they end up going down a lot before they go up to the next camp, you know, and then the last day they peak out at the peak of Everest and then come right back down. So that's an example of this. So the question might become, what about pre-acclimatization? Like before I go to those altitudes, if I don't have the ability to do that? There are pre-exposures to high altitudes in hypobaric hypoxia or devices that simulate it, which is called normobaric hypoxia, okay? So if you're going away or a patient is going to go to high altitudes, you can acclimatize somewhat by taking day trips to high altitudes before the very high elevations, okay? And if you can reach within 2,000 meters of the ultimate altitude, that's best, okay? Now, my example, back in the Inca Trail, we probably started at 9,000 or 10,000, maybe even 11,000. And then we went down. Cusco's like 10 or 11,000. Cusco's this city in Peru, and I got sick. We definitely were not feeling well. We went down to the beginning of the trail, felt better, and then probably on day 2 got to that 14,000 feet. So we had a little bit of this, and I think it worked out for us that way. I don't think I would have been as healthy had I gone straight to the trail. So what does this normobaric hypoxia mean? What it means is simulating high altitude at the altitude where you live. And they've used face masks or tents or chambers that basically create hypoxia, okay? So if our oxygen concentration is about 21% at sea level, these would drop the O2 to below 16%, but can take a tremendous amount of time. I've never heard of anybody doing it, but I'm mentioning it to you. It can require 8 hours a day for a week. And brief exposures are not really that effective. Repeated sprints in hypoxia could help. So if you were in this kind of environment through mask or whatever, you could do sprints and potentially improve performance at the higher altitudes. So, this would, obviously this kind of talk is more for elite athletes who are going to be performing at high altitudes. And that's where a lot of this information came from. There was, Olympics that occurred at high altitudes. This is, by the way, the normobaric. This is the tent that creates hypoxia. So the second bullet here, the interest about the altitude really started in the Mexico City Olympics, 1968. It was at 7,300 feet. And so there were definite differences in the performance of athletes who trained there or from higher altitudes versus those who came to the high altitude from lower altitudes. So endurance training at high altitude is what people try to do, right? Train at those high altitudes. And it can increase hemoglobin and alter muscle metabolism to allow more efficient use of oxygen. So we know this kind of thing, happens with, cyclists and athletes like that. Some other common sense preventive measures, avoid alcohol and sedative hypnotic medications during both acclimatization and at altitude. So at the very least, patients who are going on their trip and going to have alcohol need to hydrate a lot and try not to exert themselves too much in the first days of the trip. And that's the second bullet point: avoid vigorous exertion at altitude if you can. These increase not only the risk of acute mountain sickness, but pulmonary edema as well. And I think that's all I have. So I'm going to open it up then to any questions or comments and experiences that some of you have had, either personally or with your patients.
So Brian, one of the last slides you put up with the training, the sprints, reminded me of a few years back, Marshawn Lynch was endorsing this face mask that he would wear while he was training that actually had him in a lower oxygen environment. It would, and so he claimed that it actually made his training more efficient. So, I mean, maybe he was looking at the evidence there and seeing that, but I think he was wearing it more than just with sprints.
Yeah. It probably could help some. I don't know, marginally how much, and I don't know the specific research on that. Everybody's trying to get, there's a razor thin margins, I think, when you get to that elite level. I'm pretty sure that the 100% oxygen on the sideline is not doing anything. I know that's not actually, that's not related.
But they do it anyway.
We all shake our heads. It's CO2. So, but that's not an altitude comment. Has anybody had their own experiences with their own altitude sickness? Your own trips?
I've definitely had acute mountain sickness before, and the headaches, going up to altitude.
Definitely had the headaches, yeah. Headaches for sure.
That is, I mean, that's headaches plus anything else. So if you feel like kind of nauseous or sleep problems, that's AMS.
Absolutely.
Yeah, I've had AMS a couple times when I was in Utah hiking on mountains.
Mm-hmm.
Out of fun.
How high were you? Do you remember how high?
I think 10 to 12,000 feet.
Mm.
Yeah.